Here's a question. If you have a tooth that needs a crown, do we also have to do a root canal treatment too? I don't know, I'm just assuming that maybe because we assume that every root canal treatment tooth needs a crown, every tooth that needs a crown should have a root canal treatment. It's confusing, I know. But this is a very poorly understood common question. So let me try to answer these questions from different angles, but we have to agree on some facts first. Fact number one, the best root filling that you can have is actually a vital pulp. Vital pulp can and have the capacity of protecting itself from any bacteria. It can causes sclerotic dentine, it can deposit tertiary dentine, and also it can take care of any endotoxins that make it to the pulp by removing it using inflammatory cells. Compared to the gutta percha cannot protect itself, and we know that it doesn't seal the dental tubules. So if there is any marginal leakage or any secondary caries to gutta percha, it will lead to apical periodontitis. Fact number two, when we do root canal treatment, we remove extensive amount of dentine, and that often leads to weakening the tooth. And especially if you don't do a conservative access, you actually might end up needing a post and core. So generally speaking, having a root canal treatment will need probably post and core and weaken the tooth. The next question is, what kind of things that can lead to harm the pulp when we do a crown prep? Factor number one, the most common way of destroying the pulp when we do a crown prep is actually frictional heat. Especially if you don't use water coolant effectively, and if you put the high volume suction next to the handpiece, you're actually going to take most of the water that is going to reduce the frictional heat, and without you knowing, you're going to destroy the pulp. Number two, if you don't use fresh and new burrs, because if the cutting efficacy of a burr is low, it's going to cause frictional heat, and ultimately it's going to increase the blood pressure of the pulp and causes permanent damage to the pulp. So before you cut a crown, my advice is to check the volume of the water, and there are some nodes underneath the chair that you can change and increase the water volume to the maximum, and also use a fresh new burrs every time. Some studies have shown that if you use the burr 5 times, the efficacy of that burr is going to be used. Once you're done with the crown prep, your temporary has to be really good. You don't want any marginal leakage that could lead to any sensitivity. Another thing that can lead to post-op sensitivity is when you acid etch the crown too much. There are some studies that have suggested that you either dilute the acid etch or you can limit it to 10 seconds. What is even better is when you deal with, especially when you deal with vital teeth, it might be a good idea to actually use self-etch adhesives. The adhesive efficacy is not going to be that high, but at least you're not going to expose the dental tubules. In fact, you're going to incorporate some of the smear layer into the composition, which some people think it's a bad idea, but I think it's a good idea because you're going to seal these dental tubules and prevent any post-operative sensitivity. And even if the bonding is not going to be that good, it's going to act just like any good luting cement. The last part that I would like to talk about is the remaining dentine thickness. What I mean by that is the the amount of dentine that is going to be left between the prep and between the pulp. And it is suggested that it has to be at least 2 millimeter. Sometimes we prep too much, and if it's below 2 millimeter, there will be some sensitivity. Luckily, and nowadays we have more and better materials, ceramic materials or zirconium, that you don't need that much of a prep. In fact, and if you use, for example, monolithic lithium disilicate, you only need one. If you use a monolithic lithium disilicate ceramic, you only need 1 millimeter of a prep all around, even the occlusal clearance. And if you use monolithic zirconium, you only need 0.6 millimeter from all around. There is a misconception between the zirconium monolithic material and also the zirconium base, and then you layer it or veneer it. That actually need 2 millimeter of occlusal clearance. All right, so having said that, some teeth are going to be sensitive. So a good idea would be to recheck the vitality of the pulp after the period of the prep. So if you are cementing the tooth after a week or 2 weeks, or if it's longer, then before you final cement the crown, just make sure that the pulp is not sensitive, or if there is any, because some teeth are going to actually go necrotic without any sensitivity. So you want to make sure that you diagnose these necrotic teeth before you do the final cementation.